Good afternoon, everyone. My name is Kevin Kirkpatrick, CEO of the Avery Professional Group. We are a physician and physician executive lead recruitment firm. Today, my guest is Dr. Nadia Alam. Dr. Alam is a leading physician in Ontario, has worked in a lot of different roles within the system as a clinician, and has also been a very strong advocate for improving healthcare. So thank you for taking the time to talk to me.
Thank you, Kevin, for having me on the show.
Right. I part of the this is kind of a last minute thing for us, so I'll apologize to the live stream folks if we bump around a bit because we haven't had much planning. But earlier this week, you were interviewed by one of the newspapers and about kind of the state of healthcare and stuff like that. Can you give me the 30-second kind of elevator pitch of what the alarm was?
The crisis is that mid-career physicians like myself are leaving family medicine. And while I haven't quite made the decision to leave, I don't know how much more time I've got left in me to keep doing this. The problem is, as I told the journalist Avis Ferraro, that I love family medicine. I love it. The moment the patient walks into my room to the moment they leave, I enjoy the time with them, even if it's hard. I had to tell someone that they may have cancer this morning. And then I had a little kid walk in for a quick checkup and to see how they were doing because of their ADHD. All of that stuff I love. I love doing it because I really care about my patients. They're the reason I keep coming back. Mm-hmm. But when they leave the office and I'm faced with a mountain of paperwork that I know that I will be continuing late into the night, I don't know how to wrap my head around. I feel like I'm defeated every time. I just can't get ahead. I can't make a dent in it. It's a self-perpetuating problem. And this administrative burden of not just trying to be a really good doctor and be a good business person to keep my office running, but to keep up with all of the paperwork, all of the forms, all of the blood tests, the consultations, all of that. It feels like a losing battle.
Mm-hmm. Well, and it's, I think, and you just referred to it, but I read an article, I think it might have been in the Globe, that was saying that on average, a physician has about 18 hours a week of unpaid, I'd like to put that in big parentheses, unpaid paperwork,
yeah.
Right? And the reality is, we talk about technology and things like that, and it seems like it's almost like a chicken and an egg scenario where we bring in new technology that allows us to report on things and stuff like that, which predominantly seems to relate to finances. But it just keeps eroding the time away from the physicians.
Yeah, there was an article written by Dr. Abraham Verghese. It's a bit dated now. It's a few years ago, but the principle holds, the quote holds. He wrote that the patient in the bed, in the hospital, or in the clinic has now become an icon, a placeholder for the real patient who's in the computer. That's a sad statement of affairs. It's and it's true. The EMR, the electronic medical record, was supposed to revolutionize primary care and office-based care and hospital-based care because it's supposed to be much more advanced. It's supposed to set up reminders for preventative care. And it does do that to some degree. And I can't imagine running an office without an electronic medical record.
Yeah.
The challenge with it is that you really do spend a lot of time charting. You spend a lot of time reviewing reports that come through the electronic medical records 24/7. I might go to bed. Like last night, I stayed up until 1 a.m. doing paperwork. Sorry, that's my daughter in the background. She's here with me.
That's okay.
And is sick. I was up until 1 a.m. doing paperwork. And I went to bed exhausted, but thinking, okay, you know what? I had called some patients about test results. I want to follow up some of them. Some of them I filed because they're just routine screening, although the majority of them require some sort of decision making. Mm-hmm. And I went to bed thinking, okay, I've got 50 reports now in my inbox. I've got 12 forms to fill out. That's not bad. I can live with that. I can work on it some more tomorrow. I wake up And there's 70 messages in my inbox, plus 40 more that are coming through from the health report manager, plus now
Right.
2 more forms to fill out in addition to what I had. It's constant. It's a constant influx of paperwork. It just takes over. I spend more time doing paperwork now than I do in front of my patients.
Yeah. What's the paperwork? What is the purpose of most of this paperwork? Like, is it recording patient interactions for future reference? Is it, like what you mean? And it's, how do we replace it?
So one of it is, right? One of the aspects of this paperwork is the charting that's involved, keeping track of your discussion with the patients. Complex patients, however, have complex needs. They're going to come in with more than one illness, more than one concern that are equally important and that are necessary to manage. So as complexity increases, the ability to do it all in a 10-minute appointment vanishes.
Yeah.
Right? It takes me at least 20 minutes to book an appointment and go through the concerns, all of which, again, like I said, are important and must be managed for their health. Right then and there. So charting takes a long time because I've got subheadings, right? I've got heart failure, kidney failure, diabetes, high blood pressure, mental health, psychosocial stressors like income insecurity, all of that to document. And then I have to do something about it, right? Maybe it's changing a medication. Maybe it's ordering an investigation. So some of the paperwork that comes through is exactly about that, following up. Following up on those reports and results. And again, that involves some decision making. It also involves reviewing what I've discussed with the patient, because I don't just have one patient. I don't just have 10 patients. I've got about 600, which is considered a small family practice in Ontario.
Yeah.
The average family doctor has about 1,300. The ones who have the largest practices have about 2,000 to 2,500. So every time you see a report, you go back, you review, you look at it, and you think, okay, what am I going to do next? Do I have to do anything next?
Yeah.
And then there's disability forms, insurance forms, government forms, home care forms, and then prescription refills.
Yeah.
So
Well, it's interesting. I think we're both in this Facebook group for Ontario physicians, and someone posted a walk-in clinic opportunity, and it said you will see 10 patients an hour, right? And I understand the financial logic, right? I did some work in medical real estate, so I understand what it's necessary. But the problem is the financial remuneration requires that you see 10 patients, 8 patients an hour. Otherwise, you can't meet your staff because staff wages have gone up. Rent has gone up, and things of that nature. So you are almost forced to, in order to manage the business itself, and which then means 10 an hour means you're getting 6 minutes per patient. Well, math is math, right? Like at the end of the day, you're either going to go run late, which then means you're going to be longer in your clinic, and every person after that person is going to be there. But there's no way you can manage something in 6 minutes. Like that to me is unrealistic. And I think Ontario needs to start looking at different models as well, because like I do some work in PEI. And one of the things in PEI is that they pay for your office expenses.
Yeah.
Right. So if they pay for your office expenses, there's not as much pressure to see as many people because you're not keeping track of the financials. And they pay a salary. I'm not saying salary is the fit for everybody, but we have to look at how we reward physicians for their time, all of their time. And we have to, and this was part of I just shared another podcast earlier. This is part of it. Until we start taking care of the healthcare providers, and this is everybody from physicians to nurses to physiotherapists to lab techs, until we take care of them and make their job easier, we are not going to retain, and we're going to continue to have a hard time recruiting because, nobody wants to go somewhere where they're going to be abused, right? And that's a bit dramatic, but it seems to be the case. And I've been recruiting physicians since 2004, and I haven't seen any major things to make the life of a physician easier. We've created family health organizations, but I don't necessarily know that that's done much other than maybe cost containment for the ministry, right? And creating teams, because nurse practitioners still can't bill. So the nurse practitioner is an additional cost for the physician potentially, and they require support as well. So it's not like we can remove that worry from the physician by implementing a nurse practitioner, right? So, you're obviously very experienced and stuff like that. Have you thought of things that we can do to improve this?
So for one, we're coming upon that scary time, which we did back in the 1990s, where 1 in 4 Ontarians will not have a family doctor or access to primary care in any meaningful way.
Yeah.
When that happened in the 1990s, Ontario actually introduced, the government worked with the Ontario Medical Association and the various organizations that represent physicians, and they changed how family physicians were paid, right? They created these models that are called capitation models, where you are paid per month a set amount that is supposed to encompass all of the care you provide for a patient. And for complex patients, that actually works really well. Because you're right, I can't do anything in 6 minutes other than prescription refill or treat an ear infection. And I haven't seen an ear infection in months. Right? That's how uncommon it has become.
Right.
Instead, my bread and butter is heart failure, diabetes, complex mental health illnesses like schizophrenia. Like that is now my regular day. And I love it. I love complexity. Right? I want complex patients because it really uses all of my skills, and it's a cognitive challenge. And at the end of the day, I love patients. I love people's stories, hearing the beginning, middle, and end, and I'll never get tired of the relationship you build. The problem with the revolution that the Ontario government started back in the early 2000s in terms of physician funding and creating teams to support family medicine and primary care, they stopped doing it. They lost the vision. They ran out of steam. And what's happened in the meantime, patients have changed. The healthcare system has changed. And the environment, the technological environment that physicians work within, and primary care particularly, has completely turned around. And without keeping pace with those changes, we are going back in time. We are literally regressing to the 1990s again. You're right. PEI is fantastic. It's ahead of the game in paying for overhead. If I didn't have to worry about overhead, then I would be willing to stay and spend more time with patients. I would have money to perhaps hire a scribe and create an administrative team around me. We always talk about clinical teams, right? Nurses, nurse practitioners, pharmacists, OT, PT, all of them working together with the physician to care for the patient. There's also administrative teams where you set up the office to minimize the paperwork that's involved in the clinical encounter. So someone else is trained up to do the preparatory work, make sure the blood work's there, make sure all the investigations are there for you to look at and interpret. There's a scribe in the room taking notes so that you are focused entirely on the patient and you are looking at them, you're examining them, you're listening to them and not staring at a screen. And then afterwards, there's a summary of the encounter that's given to the patients, right? Particularly for complex patients where all of the steps are written out, all of the discussion is written out for the patient to keep for their own records and keep track of their own health. So having something like that would help significantly, would help me stay in family medicine and actually do the job that I love, but I'm also trained for, right? I'm not supposed to be a highly paid clerical worker, which is what another physician called it in an article that I read. Manitoba and BC have now followed suit. They help pay, they give extra funding for complex patient care, which is what's becoming the bread and butter of family medicine, but they also help pay for overhead. So that the focus again instead turns to making a practice more efficient, making a practice more joyful for not just healthcare workers, but for patients who feel like they've been seen as a person.
Well, it's one of those things that I think I've done some work with organizations that do preventative medicine, like the telesis and stuff like that. And it's interesting because they're kind of on the they spend more time with patients, but the money comes from somewhere else, right? So there's, until the government starts understanding that that's probably a better model of care, but fund for that, right? And I think, I've worked for 3 hospitals, and the amount of administrative money that's spent, is pretty exorbitant, right? And I think that we need to figure out how to have people doing the best thing at the right time, right? So I had someone reach out to me today. They've got an app called Block, or Blocks, BLOKS, and it's for things like this. It'll scribe and summarize all my video meetings and my Slack channel and all these other things into a digest for me, right? And then I actually have a staff member who works for me that his entire job is to fill my calendar with physician meetings, right? Because where I add value is on the phone with the physician or on the phone with the client, not sending emails and reaching out to people on LinkedIn. So because my model allows for a certain economic feasibility for that, I pay someone, they do that. And then I have someone else that does that too. And then these people allow me to spend as much time on the phone talking to physicians and talking to clients to understand their needs and the fit. So, it's those exist, there are tools and terms and stuff like that and things that exist for these spaces. It's just getting the whether it's political will or the motivation to do something about it, right? And we have U.S. clients that, because the remuneration is better, they have billing clerks, they have scribes, and there are entire companies that specialize in providing scribes. That allows it. And until we start sitting down and saying, okay, what does Dr. Alam do all day? How do we make sure that her entire day is spent with a patient and someone supporting the rest of the stuff? We're going to keep burning people out, and we don't have a support structure to burn people out. It's hard to get a locum if you want to take time off, right? And sometimes getting a locum actually makes more work for you in the transition back and forth. So it's kind of challenging. So
even taking time off, right?
Yeah.
Even taking time off creates challenges. I took off a week, and I promised myself I would do 2 days of paperwork, but the rest of the time would be focused on the kids, on making sure that I got a break, all of that. I came back, and it took me a month to catch up to what I had missed. It was brutal. Like it says that I shouldn't go on vacation. That's what it tells me. Well, but I can't accept that, right? That is not okay.
Yeah,
right?
and you mean
we didn't even go that far away, but it was just so punitive to go away.
Well, and as we see your daughter showing us her Squishmallow earlier, right? Like, you've got a sick child, and she's at work with you because you have to see your patients, and then have to talk to some recruitment guy on the internet. But I think I think what BC is doing is good, and I think Manitoba is going to do it as well. And I think realistically, I'd love to see this notion of a pan-Canadian licensure as a starting point to allow some mobility because sometimes change is just as good as a break too, right? So having the ability to have someone come and take over for a week so you can go skiing or somewhere, or to a beach somewhere and not worry about your patients. But I don't know how to quantify this from a cost benefit analysis, but until we take care of the physicians and the nurses, it's not going to get any better, right? Like changing the EMR to be the new one with AI is not going to change. It's not going to change the work, right? So, I appreciate that. And I appreciate both your time today. I hope you do get some time to give her some, here, I'll give you my professional opinion. Some chicken soup, maybe, right? Some ice cream, right? Ice cream heals everything. That's what my kids tell me, right?
We do. We've got ice cream. Mommy saved some just for you. Now, the one thing I will say, I truly do believe, and I've learned this over the years, I do believe that the government's in a tough position. They have to make difficult decisions under scarcity, right? And And so they do reduce everything down to dollars and cents because they have to. They have to decide who they're going to fund with the taxes that people in Ontario pay.
Yeah.
The one thing I will say, if people are sick, they're not going to be able to work. They're not going to be able to contribute to the economy. They're not going to be able to pay taxes. Yeah. And that's a big consideration for any government. Healthcare is key to everything else. It's the foundation for a lot of trickle-down effects in terms of productivity and healthy, happy citizens. The McKinsey actually did an analysis of healthcare, and they found that for every $1 invested in healthcare, you get a return of 4.
Okay.
How insane is that? Right? That is extraordinary to me. The High data that just came out yesterday, it's the Canadian Institute of Healthcare Informatics. They do a lot of Canadian research on healthcare workforce and other things. And one of the things they noted was over time, since 2020, the percent of the growth in other healthcare workers has grown slowly but steadily over the past 3 years, except for family medicine, which has declined. And that is a red flag for the province because we only have 2 front doors to the healthcare system: emerge or family medicine. If you lose family medicine, people go to the hospital, and that's not the best place to get healthy for most people.
Well, and it's causing other issues there, right? Like, because they've got bed shortages, which then means more people in emerge. So that person that should be seen in an hour is now 13 hours or whatever it may be. Like the system needs help. And I've worked for hospitals. I understand the financial aspects and the needs for it. I struggle with whether or not the decisions are engaging the right people and whether we're leading from the clinician up, right? And this is not to say that I don't appreciate CEOs, because there's some fabulous CEOs in this province, and there's a lot of hospitals doing amazing things, and there's some people at the community level doing amazing things. Like, I interviewed a family doc who was developing a palliative care toolkit for family physicians, and it was to allow and help family physicians do stages of palliative care without having to refer to someone else, right? So that's the thing that I think we lose, is that there's a lot of challenges and there's a lot of things that are bad. However, what I found in this province is there are some amazing human beings doing amazing clinical work, and we probably need to acknowledge and understand what people are doing so that we can do best of class across the system and not in pockets, right? And I think that comes down to engaging frontline physicians more in what they need, and because given the need for family medicine, we shouldn't have a round of CARMs not matching. Like those, right? Like we should be matching people right on the first go and quickly, and we shouldn't have family medicine physicians training in the US that are Canadian and wanting to come back, right? So, there are some decisions that have been made at the political level that are affecting this. And I just want people to take care of your family physician to make sure they know they're appreciated, because without them, the system will fall apart. And let's start looking at what the family physicians need. And anybody that wants to say it's just about money is full of it. This is about the system, and how do we ensure that a key important part of the system is supported and able to do their job properly, right?
Yeah, and I agree with everything you said. We need a sustained vision for changing the healthcare system, one that adapt to changing patient needs. We have a bigger senior population. I'm one of the few physicians in my area who does house calls. A lot of seniors, these elderly patients, they can't come to see me in office. It's impossible. And yet it's a complete financial loss to go see them. I do it because I love it. I love doing house calls. But it is, as a business model, it's a failed business. And it's not even just failing, it's failed. And if we don't invest in programs that help support things like that for a population that is aging, for a population where seniors outnumber kids
Yeah.
now, we've got a problem that we need to fix and fix. Otherwise, it won't just be primary care crumbling, it'll be
the whole system.
Entire healthcare system crumbling.
Yeah, excellent. Well, listen, I have taken up a bunch of your time. I appreciate it. I followed you on Twitter for a while, and we've connected in the past, but it's nice to actually get to put a face to the name and talk. I hope your munchkin feels better quickly.
Thank you.
And I hope you spoil her with as much ice cream as she can eat without getting sick. And
she's gonna milk that, Kevin. Thank you.
That's it. I can't write a prescription though, so there's nothing I can help, right? So, and that
the dentist is gonna love me.
The dentists are doing okay though, right? So, they don't mind. They might encourage more ice cream and candy so that they can do some more stuff. I'm just finishing up braces, so the dentist. Oh. I think I helped the dentist get a boat. So. We'll see. But listen, take care of yourself. Have a great weekend. Hopefully you'll get some time with your family. And thank you for taking care of us, the people in your space. But I need you to understand, I appreciate the fact that you stand up and fight for healthcare and as a member of it, because your voice needs to be heard. And I think that how you message it is in an appropriate way that people will understand. So thank you.
Thank you, Kevin. That means a lot.
All right. And take care and good luck. I hope you get some time off, and I can come see your patients for a bit. Tell them
ice cream for everybody.
Ice cream and golf. Those are my things for everybody. Okay. If you're feeling bad, go play golf. If you're feeling good, go play golf. If you're hungry, just eat ice cream. So, all right. Have a great one. Take care.
Bye-bye.